Today we are going to get a hint on that, and then beyond in the 22nd century, we want to see AKI management or sepsis management or other toxic management in the 21st century. And Dr. Bagha, all of us know him, is a nephrologist, head of nephrology and transplant at MP Shah Hospital. He's a physician and a nephrologist qualified from South Africa, Stellenbosch University. With those few remarks, Dr. Bagha, please take us through in the next 20 minutes. Welcome.
I have it, thank you. Minimize those things down. It's not difficult. Yeah, thank you. Okay, so good afternoon. I'll be discussing on hemoperfusion in COVID-19, septic shock, and liver failure. Unfortunately, the chair has told me that I have only 50 minutes, so I'll try to complete this within the 50 minutes, as told by Dr. Owiti. Okay, so I'll be discussing on hemoperfusion. So okay, yeah, so just as by the way of introduction to what hemoperfusion is. So hemoperfusion is an extracorporeal blood purification modality that consists of the passage of anticoagulated whole blood through a device that contains adsorbent particles. And these adsorbent particles are the ones that basically remove the toxins and the cytokines. So toxins with a molecular weight ranging from 100 to 40,000 Daltons bind to the particles and are removed as blood exits the column. Higher molecular weight solutes are adsorbed less efficiently, and the hemoperfusion can be used with normal dialysis machines, the CRRT machines, and also ECMO, where ECMO is available. It is used to complement existing blood purification technologies such as hemodialysis and or CRRT in the management of drug or chemical toxicities and hepatic encephalopathies. Okay, so it can be used in patients who present to us with acute liver failure or acute on chronic liver failure. Recently, it has been studied in patients with sepsis and septic shock to aid in the removal of cytokines and modulate the immune system. The Soben device system is made up of granules such as either activated charcoal or ion exchange resins or non-ion resins, which are encased in a plastic housing with a blood inlet and outlet. Now, unlike dialysis, there's no other inlet for the dialysis, for the dialyzer. So its main indications are the removal of the lipid-soluble, highly protein-bound toxins that are not easily removed with the standard hemodialysis. It has also been used in the removal of cytokines in septic shock patients, and this has gained a lot of momentum in the past few years because we know that the mortality in septic shock patients is very high. For the past almost 2 years, because of the pandemic that we are in of COVID-19, it has also been used in COVID-19, and a number of studies have actually been published. It can also be used in the removal of antibodies and antigen-antibody complexes in autoimmune and other disorders. And as I mentioned earlier, it can be used in acute liver failure or acute on chronic liver failure, where it removes hepatic toxins. Okay, so I'll start off with the COVID-19, and just as a by the way of introduction for the coronavirus. The coronaviruses are a large family of viruses that cause illnesses varying from the common cold to more severe diseases like COVID-19 in our setup right now. And there are 4 types that cause 20 to 30% of common cold infections each year in adults. Common in many animals and can be transmitted between animals and humans, and this is what is thought to have happened for the SARS-CoV-2. They can cause the severe acute respiratory syndrome and the Middle East respiratory syndrome. So it was identified, the 2019 novel coronavirus was identified as a cause of outbreak in the Wuhan city in China on 20th December 2019. Not previously identified in humans, it's suspected that it has crossed over from bats. The first case in China was linked to an animal market, and the virus was aptly named COVID-19. The first case in Kenya was diagnosed on 12th of March 2020. Currently in Kenya, there are more than 240,000 confirmed cases. This is today's data with more than 5,000 mortalities. Okay, so this is a pictogram of how the coronavirus or the COVID-19 virus looks like. There's an envelope protein, which is here. We have the spike protein, which is what was generated a lot of interest in terms of its pathogenesis, as well as in terms of the vaccines. We have the membrane glycoprotein, and then we have the single-stranded RNA virus here. These are the classical symptoms of the coronavirus, which all of us know. Now, fortunately, majority of the patients who get COVID-19, almost more than 80% tend to get the mild to moderate symptoms, okay? Only 14% tend to get severe symptoms characterized by dyspnea, hypoxia, or more than 50% of lung involvement, and only 5% develop critical COVID-19, which is characterized by respiratory failure, shock, or multi-organ dysfunction, requiring critical care admissions. The risk factors for severe illness is age more than 80 years and patients with underlying comorbidities like cardiovascular disease, chronic respiratory diseases, especially asthma or COPD, and even diabetic patients tend to get very severe disease as well. The diagnosis we all know requires the RT-PCR. Now, this is the natural history of the disease. Majority of the patients basically just reach stage 1 and their body manages to clear up the infection. There are some patients who go into stage 2 and very few patients go into stage 3, which is basically characterized by ARDS and shock and multi-organ dysfunction. This pictogram basically is depicting the life cycle of the coronavirus. So the SARS-CoV-2 basically binds on to the ACE2 receptor, which is found in multiple cells, including the alveolar cells, which is where majority of the infections take place. So the spike protein basically binds to the ACE2 receptor, and then the envelope protein fuses with the host cell membrane, and the virus enters the cell. The single-stranded RNA subsequently translocates into the nucleus, where it undergoes transcription and translation, and more viral particles are released and subsequently infect other cells. Now, when the virus enters the body, it basically activates the immune system. Your polymorphonuclear leukocytes and macrophages are activated. These activate your immune system. Your T cells are activated, and subsequently within the lungs, we have the alveolar cells type 1 and type 2 that are being activated, and they lead to release of these cytokines as well. Now, within the cell itself, within the nucleus itself, you also get the interferon gene that is activated and leads to stimulation of interferon release, which also leads to increased cytokine release as well. So all of this basically leads to what is called the cytokine storm, and this is what leads to damage to the lungs and the other organs. So it leads to necrosis, tissue damage, and subsequently you tend to see a DIC-like picture as well setting in. Now, this is a sorry. So the upper one was basically the picture of a normal capillary, yeah, which is showing a nice intact endothelium, one neutrophil here, very few platelets, and deformable erythrocytes. This is a picture of a capillary that has been damaged by the cytokine storm. You can see that the endothelium is not intact. There's glycocalyx shedding. There are multiple thrombocytes present, and even the RBCs have become deformed as well. Okay. So the interferons are very, very important when it comes to trying to inhibit the replication and the spread of the virus. So when the interferon gamma gene is activated, it leads to release of the interferons. The interferons basically bind to the interferon receptors on the other cells and leads to activation and production of the antiviral proteins. And these antiviral proteins tend to inactivate so they tend to inactivate the COVID-19 proteins as well. The interferons are also very important in terms of causing apoptosis of the infected cells as well. So what happens is the virus has found a way of inhibiting the interferon release earlier on when it infects the body. And this is what helps it to infect the other cells as well. And subsequently, this is what leads to the cytokine storm, okay? So the SARS-CoV-2 is the third fatal coronavirus that has emerged in the past 2 decades. And the cytokine storm is a frequently occurring feature of the severe infection that we have seen with the SARS, the MERS, and the H5N1 influenza and the H7N9 influenza. The cytokine storm is associated with disease severity, as I'll show you with in the in the coming slides, and it is a predictor of mortality. And studies have revealed that the lethality of the COVID or influenza virus is related to the induction of excessive and aberrant immune system response. Curbing the overt inflammatory response induced by COVID-19 may be essential for reducing mortality among the critically ill COVID-19 patients. Okay, so this is where by now the hemoperfusion was thought that it will work for the critically ill COVID-19 patients. And hemoperfusion has been there for quite some time. As I told you that initially it was mainly used for removal of toxins and poisons, but now it has been used for sepsis. So this was basically an earlier paper that was published by Professor Claudio Ronco. He was looking at polymyxin B hemoperfusion and was giving a mechanistic perspective. So what this entails was basically the adsorbent column was made up of polymyxin B, and the polymyxin B was adsorbing the pathogen-associated molecular proteins, and in this case, it was a lipopolysaccharide, and it was removing the endotoxins from the blood. Okay, so this can be used together with your normal hemodialysis machines, like in this setup. Okay, so blood comes out from the patient, passes through the adsorber, and then the purified blood basically gets back into the patient. These are several studies that have been shown, that have been done at looking at cytokines in relation to the hemoperfusion therapies. I've highlighted a few of them. Sorry, I can't read from there. So basically what they were looking at is patients with refractory septic shock or septic shock with ARDS. They also looked at patients who are on the cardiopulmonary bypass machines, those patients undergoing heart transplants or cardiopulmonary bypass surgeries as well. And what they found was that the highlighted ones actually showed that there was a significant reduction in your vasopressor requirements, as well as in some of these studies actually showed a mortality benefit as well. Now, remember that part of the cytokine storm is also activated, not only in COVID-19, but in sepsis patients, is activated by your damage-associated molecular proteins, as well as your pathogen-associated molecular proteins. And the hemoperfusion basically removes these endotoxins. Okay, so what is the rationale of blood purification on COVID-19? So what happens is that there is a possible mechanism of innate immune system on the severity of the disease. As I mentioned earlier, what the virus does is that it suppresses the interferon response during the initial infection, and the viral replication, which goes on unchecked, triggers off hyperinflammatory condition and a cytokine storm. And there's an influx of activated neutrophils and inflammatory monocytes and macrophages. Okay. So this was a study from China, which was looking at the risk factors for severity and mortality in adult COVID-19 patients in Wuhan. And what they found was that the serum cytokine levels of interleukin-2, interleukin-6, and interleukin-10 was significantly higher in those patients who had critical COVID-19 as compared to those patients who had non-severe disease. This was another study that was looking at the risk factors associated with acute respiratory distress syndrome and death in patients with coronavirus. Again, it was in Wuhan, China, and what they found was that the patients who had an increased mortality were those who had a very high level of interleukin-6. And if you look, currently we have data that shows that inhibiting the interleukin-6 basically has been shown to have a mortality benefit. And this is why we're using the interleukin-6 inhibitor tocilizumab routinely right nowadays for the critical COVID-19 patients. Now, another important aspect to bring out is that for the critically ill COVID-19 patients, the coronavirus itself basically leads to a cytokine storm, but even our own therapies like ventilation, mechanical ventilation, and for those people who are doing ECMO, especially in South Africa, these two therapies also lead to an increase in your cytokines as well. And this is what perpetuates a cytokine storm, leads to multi-organ dysfunction and subsequently shock as well. So we can use different approaches for the cytokine removal using hemoperfusion. We can use a direct hemoperfusion using a nitrous macroporous sorbent. We can use plasma adsorption on a resin that after plasma separation from whole blood, but this is a bit more tedious. We can use a continuous renal replacement therapy with hollow fiber with adsorption properties, and a high dose CRRT with a medium cutoff or a high cutoff membranes. So cytokine removal is mainly carried out using a neutro-macroporous sorbent. And what we tend to do is that we tend to use this therapy for 3 hours or more. But currently, I mean, from my experience, I've used it for 3 hours, for 3 to 5 days, and it has worked wonderfully well for our patients. This is a statement from the NICE guidelines that has given emergency approval for using cytosol therapies for COVID-19 patients, especially those who have very high levels of cytokines in the blood. Okay. So these are the other studies that were done with hemoperfusion. One was in extrapulmonary sepsis-induced acute lung injury, and one was in severe acute pancreatitis. And what they showed was that it basically helps to reduce the level of cytokines and subsequently improves your hemodynamics as well and reduces your length of ICU stay. Okay, so you can use the hemoperfusion directly, or it can be complemented when you have patients who have developed AKI, and they can be used with hemodialysis or hemodiafiltration or SLED or CRRT, and can be used with your ECMO as well. So this is the Cytosol Absorber, okay, which has been introduced into the Kenyan market. So it's basically approved with the standard hemodialysis, hemofiltration, ECMO, and heart-lung machines in hospitals worldwide. So the Cytosol comprises of several important features, and it has an advanced biocompatible and hemocompatible porous polymer sorbent-based technology with extremely high binding capacity. So in regards to the cytokine removal, the goal is to reduce but not to completely eliminate the cytokines. So that becomes very important. So our goal in hemoperfusion for cytokines is not to completely eliminate the cytokines, because remember that there are the anti-inflammatory cytokines as well. So this helps to keep the immune system intact, but remove the dangerous cytokines that are causing more damage. So it is a whole blood adsorber, and this is how the cytosol absorber looks like. Basically, it has the a highly porous, high-tech polymer beads, okay? And this is where the blood actually, whole anticoagulated blood passes through. So we discussed this. So this is a range of the cytokines and the damage-associated molecular proteins, pathogen-associated molecular proteins, cytokines. The cytosol removes, you can see all the way till 60 kilodaltons. It can remove all of these cytokines and the PAMPs and DAMPs. Okay. So this was a paper that was published in one of the journals, which was basically looking at CRRT with a disposable hemoperfusion cartridge in a patient who had got critical COVID-19. So this patient was admitted in the ICU. Initially, did not have a very low saturation, but subsequently, before hemoperfusion, you can see that his chest X-ray is significantly worsened, has developed severe ARDS. They initiated hemoperfusion using the HA380 cartridge, and after the hemoperfusion, you can see significant changes in the chest X-ray, and the patient was actually be able to be weaned off the oxygen as well. So FDA has actually given emergency approval as well for the treatment of critical COVID-19 using the cytosol therapies. Okay, and of course, we are supposed to be very careful when selecting our patients who are going to get these hemoperfusion therapies. So this was basically for COVID-19. How about sepsis and septic shock? Because you also tend to see a lot of these patients as well in our ICUs. So sepsis is a syndrome of physiologic, pathologic, and biochemical abnormalities that is induced by infections. It's a major public health concern, unfortunately, because it is accounting for more than $20 billion US costs, of the total hospital costs. And this is data from the US, but from our observational studies, we have also noted that sepsis and septic shock is the most common cause of morbidity and mortality in patients. The reported incidence of sepsis is increasing, and it is the leading cause of mortality worldwide, including in Kenya. When we used to do our mortality meetings in Aga Khan University Hospital, when I was a resident, majority of the patients basically were dying because of sepsis and septic shock. Unfortunately, those patients who survived sepsis have a long-term physical, psychological, and cognitive disabilities. They have to undergo vigorous physiotherapy and rehabilitation even after discharge from the ICU. Now, sepsis, the definition of sepsis has changed. Remember that the surviving sepsis guidelines initially used to define sepsis as SIRS plus an identifiable cause of infection. However, from the surviving sepsis guidelines 2016, this has changed. And we no longer have SIRS or severe sepsis as part of the definitions that they had. So sepsis is defined as a life-threatening organ dysfunction that is, which is caused by dysregulated host response to infection. So you need to have a life-threatening organ dysfunction, a dysregulated host response to an infection. So you have to have an identifiable cause of this. And unfortunately, in a number of our patients, including in the US, we cannot identify the source of the infection. Our blood cultures are also negative as well because of the fact that patients have taken loads of antibiotics before coming to the hospital. Organ dysfunction is identified as an acute change in your total SOFA score of more than 2, more than or equal to 2 consequent to an infection. And it has a mortality of 10% in a general hospital population. Now, the SOFA score is a bit tedious to use. So for the accident and emergency departments and even in the wards, we can actually use a modified SOFA score, which consists of alterations in mentation or a systolic blood pressure of less than 100 or a respiratory rate of more than 22. You need 2 out of these 3 to make a diagnosis of sepsis. Okay. Septic shock is a subset of sepsis in which there is circulatory and cellular metabolic abnormalities, which are profound enough to substantially cause mortality. And it is characterized by maps of it's characterized by hypotension, which requires vasopressors to maintain your mean arterial pressures of more than 65 millimeters of mercury, or you have a serum lactate of more than 2. And this is where it becomes very important that we need to do arterial blood gases for our patients who have sepsis and we are suspecting septic shock. So if you get a lactate of more than 2 millimoles per liter, then you know that you're getting reduced perfusion in your microvasculature. So when you meet these criteria, the mortality is in excess of 40%. Remember, in sepsis, the mortality is in excess of 10%. When you hit septic shock, your mortality is in excess of 40%. And this is evidenced by this data. In sepsis, you can see that the mortality, the crude mortality was 15%. By the time you're going to septic shock, your crude mortality is hitting almost 50%. Okay. The causative organism, this is an old slide, but from the West, unfortunately, we don't have, fortunately, we don't have a lot of gram-positive sepsis. Ours is mostly gram-negative. But what we are seeing right now is an increase in fungal infection. So this is one thing that we always have to keep in mind when we are treating septic shock patients who have had a long-term hospital stay. They are on dialysis or they're on the ventilator. They've had broad-spectrum antibiotics. We always need to start thinking about fungal infections. And this, unfortunately, cultures take long to come back. So if you suspect somebody has a fungal infection, please start the empiric treatments. The pathophysiology of sepsis, again, we have the pathogen-associated molecular proteins, which are your lipopolysaccharides or your gram-negative bacilli, which bind to your toll-like receptors 4 or 2. There's downstream signaling and the subsequent activation of your nuclear factor kappa B gene. And this leads to increase in cytokine release, your tumor necrosis factor alpha, your interleukin-1 and interleukin-6. The sepsis also leads to an increase in your inducible nitric oxide synthase, which leads to increased nitric oxide release. Now remember that there are different types of nitric oxide synthase. There's the inducible nitric oxide synthase and the endothelial nitric oxide synthase. The inducible nitric oxide synthase, which is produced by your macrophages, is not the good nitric oxide synthase, unfortunately. So all of this basically now leads to the cytokine release. And what this does is that at the microvasculature, it leads to the procoagulant response that we tend to see. So it leads to endothelial damage and release of your tissue factor and activates your coagulation system. The sepsis also tends to downregulate your production of protein C and protein S. And subsequently, you lead to increased fibrin production and DIC as well. So what's the pathophysiology? Is it the disorder due to uncontrolled inflammation? And this is a question that has been asked over and over again. And we have seen that a lot of studies have shown that there are increased inflammatory mediators in patients who have sepsis and septic shock, like your interleukin-1 and tumor necrosis factor and interleukin-6. But these are based on animal studies. But one study that was done in children with meningococcemia, they found that the tumor necrosis factor levels directly correlated with mortality. However, trials involving TNF antagonists did not show any mortality benefits per se. And what they tended to find is that even patients who are treated with TNF antagonists who had rheumatoid arthritis actually tended to develop infectious complications as well. So it is really unclear. I mean, initially, and what studies have shown, sorry, I not put this slide, what studies have actually shown is that in the initial phase, we tend to get an uncontrolled inflammatory response. Then subsequently, there's an energy that sets in, okay? So what happens is now we no longer have a pro-inflammatory cytokines, we tend to get more of the anti-inflammatory cytokines being released later on. So what do septic patients die from? Septic patients actually die from multi-organ dysfunction because of the unregulated host inflammatory response system, which starts off in one organ, but then subsequently because of the cytokine storm spreads to the other organs as well. So you might get a patient who has a UTI, subsequently develops ARDS, subsequently develops acute kidney injury as well. So what our aim is to basically regulate this host inflammatory response and make sure that it doesn't lead to excess tissue damage and cause multi-organ dysfunction, okay? So our goal is to prevent the patient from going into multi-organ dysfunction, because remember that the crude mortality of septic shock is almost 50%. By the time that the patient is getting multi-organ dysfunction, the mortality is much higher. So for every organ that now keeps on getting involved, your mortality keeps on getting higher and higher. So mortality is very high in septic shock patients, and despite appropriate antibiotic therapies, we have seen many patients succumbing to the disease, and it's due to the unregulated inflammatory response in those patients. So is there a role of blood purification therapies to minimize that cytokine storm and the unregulated inflammatory response? So what are there are a number of unanswered questions in blood purification therapies when they've been applied for sepsis and septic shock patients. So what is the optimal time to start hemoperfusion in patients who have sepsis? Is it when the patient develops septic shock? Is it when they're on one vasopressors? Is it they're on multiple vasopressors? Are they supposed to be ventilated patients? Can we do it on patients who are not ventilated? Can we do hemoperfusion simultaneously with hemodialysis, like intermittent hemodialysis or CRRT? What's the optimal dose of hemoperfusion? And how do we monitor the response? Remember that most of the studies are basically looking at monitoring your interleukin 1 and interleukin 6, which are your cytokines. So how do we monitor the response to our patients? Because in sub-Saharan Africa, we cannot monitor this. So should we use the CRP or the procalcitonin? So these are the basic prerequisites of using the hemoperfusion or cytosol therapies for sepsis and septic shock patients. The patients are supposed to be on the standard therapies for sepsis and septic shock, okay? Hemoperfusion is supposed to be employed as an adjunctive and not as a causative therapy. And continuous treatment is recommended over intermittent, but this is specifically for cytosol, okay? When should therapy started? Okay, therapy should be started in patients who cannot be stabilized with the conventional standard therapies. So these are patients who are developing hemodynamic instabilities. They are on multiple vasopressors. Okay, and it's supposed to be started early. And this is what we have found as well. I've used hemoperfusion mainly for COVID-19 patients. I was just talking to one of my colleagues here who has used it in Nairobi Hospital. They've done multiple sessions of hemoperfusion for critical COVID-19 patients as well. And what we have found is that once when it is started early is when you get the maximum benefit. So even for septic shock, the same thing applies as well. So it has to be onset of shock within the last 24 hours. Patient is on vasopressors. There is signs of capillary leakage, features of positive fluid balance. And you have already multi-organ dysfunction setting in, like you start getting at least one or more organ dysfunctions. Your markers of infection are supposed to be high, so your procalcitonin or interleukin 6 levels where you can do your interleukins. So why start early? So multiple studies have actually shown that there is a survival benefit if hemoperfusion therapies are started early as compared to late. And this is what I have seen as well in my hospital as well, especially for the COVID-19 patients. Those patients in which we started the hemoperfusions early actually tended to do much better than the ones that delayed. So, as I said, that cytosol therapy should be started in patients who do not respond sufficiently to the current therapeutic guideline recommendations. Okay. So this was one study that basically was looking at hemoabsorption with cytosol in critically ill patients in intensive care unit. And what they did basically was, sorry, I'll just look here. So they divided the patients into the cytosol arm versus the CRRT arm. and they analyzed for the 28-day mortality. So what they found is that the patients who were in the Cytosol arm, basically their predicted mortality was significantly, their observed mortality was significantly lower than the predicted mortality as compared to the CRRT, because remember that it is postulated that even CRRT can remove some of your cytokines as well. And I know some hospitals have been using CRRT, even in Kenya here, as an adjunctive therapy in patients who have septic shock. I think I have enough time. 10 minutes, thank you. So we'll go to liver failure. So, sorry, I'll just take a few minutes only, sorry. So, because I was asked to talk about all these 3 therapies in 20 minutes, unfortunately. So for liver failure, you don't need to switch it off. So now there's also a role of hemoperfusion, as I mentioned earlier on, in liver failure because of the toxins that develop in patients who got liver failure and the bilirubin that develops. This is a classification based on the time parameters of liver failure, where you can get acute liver failure, subacute liver failure, acute on chronic liver failure, and chronic liver failure. So what happens is you tend to get the toxins that are being produced. So they're the endotoxins and cytokines and free radicals that are produced that lead to spontaneous bacterial peritonitis. We have seen patients who have ascites because of liver failure tend to get spontaneous bacterial peritonitis. It can, there are also the aromatic amino acids that are produced, which can actually lead to the hepatorenal syndrome. It can lead to upper GI bleeds. It can lead to jaundice as well from the bilirubins as well. So acute on chronic liver failure is a high prevalence with 50% mortality rate, and the costs of treating acute on chronic liver failure and the mortality rates are far greater than those associated with more common causes for hospitalization. So the treatment modalities for acute liver failure and acute on chronic liver failure, of course, you can use the medical therapies, but not really much can be done with these patients. You can use your N-acetylcysteines, you can use your L-ornithine, L-aspartate infusions as well. But unfortunately, there's not much that can be done in patients who come in with acute liver failure. We just have to do supportive therapy. There's an aspect of stem cell, introducing stem cells into the liver so that the liver can regenerate. And then subsequently, in those patients who have fulminant liver failure, like those patients who come in with acute liver failure secondary to paracetamol poisoning, they can be offered transplantation. So the other treatment method basically for supportive care is your artificial liver support system, or the ALSS. It's an extracorporeal support system which temporarily replaces your partial liver function as well. So we have the non-biological ALSS, whereby you can use it together with your hemodialysis or hemofiltration or hemodiafiltration. You can do your plasma exchange, or, sorry, I can't see from there, you can use your hemoperfusion here as well. There's also the MARS, which is your molecular absorbent recycling system as well. So there's a specific modality of treatment called the double plasma molecular absorbing system, which basically is based on the plasma bilirubin adsorption treatment, which is a broad spectrum adsorbent. So what it does is that it can not only adsorb bilirubin, but also removes your inflammatory mediators. And there's no loss of plasma. I think Aga Khan Hospital, Mombasa have a machine that can basically do this as well, DP mass. So this is how it looks like. Basically, the double plasma molecular adsorption system, it basically uses 2 cartridges, the BS330 and the HA332 adsorption cartridges. So what the BS330 does is that it adsorbs the bilirubin and the bile acid, while the other one basically removes the molecular toxins which are induced by the liver disorders, such as inflammatory mediators, ammonia, phenol, and the mercaptans. And this is how they look like. So we'll not go into this. So this is how you basically need to have a plasma separator. So what happens is that you separate the plasma, and because of the plasma separator, which is basically reinfused back into the body after being cleared, you don't need to give extra FFPs or albumin for this therapy. So it is much better. And then subsequently, it goes through the BS330 and the HA330 cartridges. Okay. So the indications of the DP mass are liver failure and its complications, for example, hepatic encephalopathy, liver failure because of viral hepatitis and non-viral hepatitis. It can be used pre and post liver transplants. Unfortunately, we have not just started doing the liver transplants here, and can be used in severe cholestatic jaundice patients to relieve the symptoms of pruritus as well. So when you use the DP mass, it can be used in severe hepatitis with liver failure with significantly higher bilirubin levels, or you can use single treatment modalities whereby you're only using the BS330 together with the plasma filter. And we have done that as well in MP Shah Hospital, whereby your bilirubin levels are more than 10 times the upper limit of normal. So these are that it can also be used by the drug, or single treatment modes can be used where you have drugs or poisons cause liver damage. So I'll end there. I can see Ovid is about to shut off the microphone. So hemoperfusion is a modality of treatment where anticoagulated whole blood passes through an adsorption column. Initially, it was mainly used for treatment of poisons and toxin removal, but now we are using it more and more even in patients who have developed liver failure and hepatic encephalopathy. More and more studies have been done in patients with sepsis, septic shock, and in critical COVID-19 patients. In COVID-19, mortality is postulated to be due to the cytokine storm. Initially, the only treatment with non-mortality benefits was dexamethasone, but now we know that the IL-6 inhibitors have also been shown to be useful as well. FDA has given emergency approval, but for hemoperfusion in COVID-19. But if you look at Europe, Canada, China, Japan, they all have approval from their regulatory agencies for use of hemoperfusion in COVID-19 patients and sepsis and septic shock. So hemoperfusion can be used in patients with septic shock, but the caveat is that it has to be started very early. Hemoperfusion can be used in patients with acute liver failure and acute on chronic liver failure, and your double plasma molecular adsorption system has been shown to be beneficial. So I'll end there. Thank you very much.